On-the-scene coverage of ACC 2015 is supported by Effient.
I'm Peter Block in San Diego at ACC 2015 for On the Scene, and with me is Thomas Engstroem from Denmark. The DYNAMI trials have always been interesting. Now we have DYNAMI 3, which raises the question or tries to answer the question of what to do about non-culprit lesions. So, Thomas, tell me about the trial and then we'll get into the results.
Yeah, basically patients that are admitted with a STEMI has their culprit lesion fixed by means of primary PCI. And by that time, you, by angiography, get acquainted to other lesions. So we randomized patients to either only treatment of the infarct-related artery or to FFR-guided treatment of all other stenosis as well.
Okay, now I think it's important to point out that the guidelines in the United States, and I think also in Europe, say you should do the culprit lesion and then not do the other lesions, at least at the present time. Is that correct?
This is correct. So we waited 2 days before we did the full revascularization, and we sought to estimate whether there was ischemia behind the stenosis by means of the FFR.
So you really evaluated ischemia to see whether or not you should go ahead. So why did you wait 2 days? Is that an important issue?
I think that we all agree that unless you have cardiogenic shock or persistent ischemia, you should probably not do all lesions in the acute phase in order to avoid side effects.
Okay, so that was the way the trial was set up. I guess the short answer here is, or the short answer I want is, what'd you find?
We found that the complete revascularization group fared better than the infarct-related artery group only. There was a hazard ratio of 0.56, meaning that a 44% reduction in the primary endpoint in favor of complete revascularization.
So what is the primary endpoint? Was it a combined endpoint, and what drove the combined endpoint, if that's what it was, Thomas?
It was a combined endpoint of all-cause death, non-fatal reinfarction, and the need for repeated revascularization. And the primary endpoint was driven by the need for revascularization.
So the need for revascularization, you mean later on, or the need for revascularization within 2 days?
Later on.
Now, how does that work, though? I mean, I don't understand. You just let the patients who did not have non-culprit lesions go home and then bring them back if necessary. Is that what drove it?
No, the thinking is that if you leave the vessels untreated, you have a higher risk of a subsequent need for PCI. And this turned out to be true, because in the group with only infarct-related artery treatment, they came back for subsequent treatments due to ischemia. And half of the patients that returned for another procedure had it done in an urgent way because of unstable angina.
So there's an important outcome, I think, from all this for the practicing clinician out there that's doing interventions for STEMI. I mean, most of us would back away, but it sounds as though doing the non-culprit artery is clearly the right way to go. Now, what about the 48-hour delay? Do you think that's a critical issue, or is that something that needs further study?
We observed one patient that died between the index procedure and the full 2 days. And he died from cardiac rupture, so that was merely an effect of the disease itself. So we found it safe to postpone the full revasc until 48 hours after. But of course you might discuss whether you should postpone it even further, because you can discuss whether the FFR done after 2 days is reliable, or there may be some mis-evaluations at that time.
Okay, so we have a trial that may very well change guidelines, at least in the United States, when we now are very cautious about non-culprit arteries, and obviously more to learn as you go forward, but a very exciting study. Thank you.
It was a pleasure. Thank you.